Imagine arriving at a regional hospital with crushing chest pain, a high fever, or a deep laceration requiring immediate intervention. You assume that the medical staff working behind those doors operate within a cohesive community safety net bound strictly by the Hippocratic Oath. You naturally expect that every decision made in the triage bay, from diagnostic imaging to admission orders, is dictated solely by clinical urgency, board-certified expertise, and patient advocacy. Yet behind the stainless steel examination tables, heart rate monitors, and sterile curtains lies a quiet corporate restructuring. Over the last 2 decades, Wall Street private equity firms have executed a massive, highly leveraged takeover of the American emergency care delivery system. They do not put their names on the hospital building, nor do their executives walk the halls in scrubs. Instead, they operate through institutional acquisitions, buying up physician staffing agencies, ambulance transport networks, regional hospital systems, and outpatient emergency centers, consolidating them into corporate entities hidden behind complex shell structures. When you step into an emergency room today, the physician holding the stethoscope may not be employed by the hospital at all. Instead, they are often a contracted asset deployed by a private equity-backed mega-staffing firm. This shift transforms the emergency department from a civic safety net into a high-yield cash flow engine designed to meet aggressive financial benchmarks. To understand how financial institutions gained control over emergency care, it helps to examine the core mechanism of private equity investments, the leveraged buyout (LBO) and the systematic roll-up strategy. In a standard LBO, a private equity firm acquires a target business using a relatively small amount of its own capital, alongside a substantial portion of borrowed debt. A critical feature of this arrangement is that the debt is placed directly onto the balance sheet of the acquired medical company rather than the private equity parent. The acquired clinical entity must then generate sufficient operational revenue to service the high-interest payments on the debt used to buy it, while simultaneously striving to achieve target returns for the firm's investors. Executing this strategy in emergency care required aggressive consolidation. Beginning in the late 2000s, private equity managers targeted emergency medicine because emergency care represents a captive, non-discretionary consumer base. Patients experiencing acute, life-threatening medical emergencies do not have the opportunity to price shop, evaluate alternative providers, or select in-network facilities. Private equity funds began acquiring small, independent, physician-owned emergency medical practices and rolling them up into national mega-entities. 2 massive entities eventually grew to dominate the emergency staffing landscape: Envision Healthcare, acquired by Kohlberg Kravis Roberts & Co., or KKR, and Team Health, acquired by Blackstone. Together, these private equity-backed staffing giants came to manage or influence emergency department staffing contracts for a significant portion of the nation's hospitals, overseeing thousands of clinical facilities across the country. Once a private equity firm acquires a major medical staffing agency and saddles it with acquisition debt, the immediate operational focus turns toward maximizing top-line revenue. In traditional healthcare operations, physician groups negotiate contracts with commercial health insurance carriers to remain in-network, accepting negotiated, discounted reimbursement rates for services rendered. Private equity operators identified a lucrative structural dynamic in acute care: out-of-network balance billing. The mechanics of this strategy were straightforward. PE-owned staffing entities frequently opted to keep their emergency physicians out of commercial insurance networks. Consequently, when an insured patient visited an in-network hospital emergency room, they were routinely treated by an out-of-network physician managed by the PE staffing firm. The insurance carrier would pay its standard out-of-network rate, and the PE-backed staffing agency would send a surprise bill or balance bill directly to the patient for the remaining uncollected balance, often amounting to thousands of dollars, because patients facing emergency medical crises cannot select their attending doctor. Staffing firms held significant pricing leverage. This out-of-network status was used to either collect high balance billed fees directly from patients or compel commercial insurance carriers to accept significantly higher in-network reimbursement rates. For years, this structural leverage generated substantial margins, turning emergency medical care into a highly profitable segment for debt-financed asset management. When federal regulatory updates, most notably the passage of the No Surprises Act, restricted out-of-network balance billing, the primary revenue driver for out-of-network billing strategies shifted. Carrying heavy debt loads while losing an important margin driver, private equity-managed staffing entities sought to cut operating expenses to meet debt obligations and maintain performance targets. This cost containment model relies heavily on three primary strategies. 1. Replacing physicians with mid-level providers. To lower labor costs, private equity-managed emergency departments often shift clinical hours from board-certified emergency physicians, MDs and DO, toward advanced practice providers, APs, such as physician assistants, PAR, and nurse practitioners, NPs. While mid-level providers play an essential role in acute care, staffing models sometimes stretch supervisory ratios. In some cases, a single physician may be tasked with overseeing dozens of patients seen by APs, or facilities may operate during certain shifts without an on-site, board-certified physician. 2. Relative value unit, RVU, quotas and speed pressures. Clinicians in private equity-managed settings frequently face performance evaluations tied to corporate productivity metrics rather than purely patient-centered care. Emergency physicians are often tracked on relative value units, RVU, a standard measure of billing complexity and productivity. Doctors face internal targets to minimize patient encounter times, accelerate discharges or admissions, and ensure detailed chart documentation to capture higher billing tiers. 3. Lean staffing and triage delays. To reduce daily operating costs, staffing budgets are tightly managed. Nursing staff and physician hours are frequently trimmed during off-peak periods, which can lead to extended waiting room times, patients being evaluated in hallways, and an increase in patients leaving the emergency department before receiving a complete medical evaluation. The expansion of private equity into clinical management must navigate long-standing legal protections. The corporate practice of medicine CPOM doctrine. Established in many state statutes, the CPOM doctrine prohibits non-physician corporations from owning medical practices or employing physicians directly. The explicit purpose of these laws is to prevent commercial entities and financial investors from overriding a clinician's independent medical judgment in pursuit of corporate profit targets. To work within these legal boundaries, private equity entities often employ complex administrative frameworks known as friendly PC, professional corporation models. Under this structure, a management services organization, MSO, owned by the private equity entity acquires and controls all physical assets, technology infrastructure, real estate, administrative operations, and billing channels. A single friendly physician acts as the nominal owner of a professional corporation shell that technically hires and pays the emergency room clinicians. The MSO then executes an exclusive management contract with the physician-owned shell corporation, charging substantial management fees that transfer clinical operational revenues directly to the administrative parent. Through detailed administrative agreements, management entities retain operational influence over scheduling, staffing budgets, clinical productivity goals, and vendor arrangements, creating a structure where clinical operations align with broader corporate objectives. Clinicians working within these environments face professional challenges. Those who voice concerns regarding understaffing, safety protocols, or operational pressures may find limited contractual protections, as at-will contracts and non-compete clauses limit their professional flexibility and ability to challenge management decisions. Loading essential healthcare operations with significant debt carries systemic risks, particularly when market conditions shift or regulatory changes impact core revenue models. When debt servicing costs remain high while revenues tighten, clinical organizations can face severe financial distress, raising concerns about the stability of community care infrastructure. A notable example of this financial pressure occurred with Envision Healthcare. Following its 2018 acquisition by KKR in a leveraged buyout carrying over $5 billion in debt, the firm faced changing dynamics around out-of-network billing alongside shifting patient volumes. The firm struggled to meet its ongoing debt obligations, ultimately leading Envision Healthcare to file for Chapter 11 bankruptcy in May 2023. The restructuring highlighted the financial challenges inherent in applying highly leveraged capital structures to essential healthcare staffing operations. Similar financial pressures have impacted hospital infrastructure directly. The closure of Hahnemann University Hospital in Philadelphia, a historic safety net teaching institution handling tens of thousands of emergency visits annually, illustrated the risks of financial distress in urban care networks. Following its acquisition by a private equity-backed parent company, operational difficulties led to the facility's eventual bankruptcy and complete closure. The sudden shutdown removed a critical emergency safety net for the local community and disrupted training programs for hundreds of medical residents. The expansion of private equity into emergency care highlights a structural friction between short-term financial models and the delivery of emergency medical care. Emergency departments serve as vital civic safety nets, providing non-discretionary care to vulnerable patients during acute medical crises. When clinical operations, staffing allocations, and administrative priorities are shaped by aggressive debt servicing and financial targets, questions arise regarding the long-term sustainability of the safety net. Addressing these challenges presents important policy questions for the future of healthcare administration. How can regulatory bodies effectively enforce corporate practice of medicine statutes to ensure clinical decision-making remains entirely independent of administrative profit targets? What transparency requirements should be established to ensure patients and local communities know the corporate ownership structure behind their emergency room providers? How can federal and state regulators balance the need for capital investment in medical facilities with protections against excessive debt burdens that threaten facility stability? What policy mechanisms can ensure that emergency staffing models maintain safe physician-to-patient ratios while protecting clinicians who raise concerns about patient safety? Whether emergency care continues along a path of financial consolidation or pivots toward models that prioritize clinical independence and operational stability remains a central debate for healthcare policymakers, medical professionals, and the public alike. Think this story was shocking? The deeper you dig, the darker it gets. Watch our investigative series exposing the rise and collapse of powerful political empires. Hit subscribe to Corrupt Roots and tell us in the comments, what hidden trail of corruption should we uncover next?